Perfect. Thank you, Asia. Thanks again for everyone for attending this year's virtual Safe Sleep Summit. As Asia mentioned, my name is Rachel, and I am a member of the Infant Health Action Team through Flourish STL. I am fortunate to have had this year's keynote speaker, Dr. Linda Battle, as one of my graduate school professors when I was attending Grand Canyon University, and she is one of the main reasons that I fell in love with public health. Dr. Battle's background includes a bachelor's degree in biology and chemistry from St. Francis Marian University in Florence, South Carolina. She then went on to serve almost 10 years in the U.S. Army, where she served as the casualty officer for the 18th Airborne Corps during Operation Desert Storm. For her service during the Gulf War, she was awarded the Bronze Star Medal for valor, in addition to many other recognitions. After getting out of the Army, Dr. Battle received her bachelor's in nursing from Columbus State University and then went on to receive her master's degree in nursing with a specialization in public health from East Carolina University. Then in 2009, she completed her Doctor of Nursing practice from Regis College in Massachusetts, where her dissertation was titled Barriers to Faith-Based Primary Prevention of HIV and AIDS, specifically in communities of color. As a staff nurse, Dr. Battle worked primarily in women and children's health and has served as the director of perinatal services at 2 hospital organizations. In addition, she is board certified by the American Nurses Credentialing Center as a public health clinical nurse specialist. Dr. Battle currently resides in Texas, where she lives with her 25-year-old son, her 102-year-old mother, and 4 little dogs. And in her spare time, she finds it rewarding to use her nursing knowledge to help nurse little sick dogs and help them find their forever homes. She currently teaches public health nursing at Grand Canyon University in Phoenix, Arizona. That is online. And then also she works full-time for Connect Pediatrics, where she provides nursing care for some of the most medically fragile children in the Fort Worth, Texas area. I know my life has been enriched through knowing her, and without further ado, it is my honor to introduce our keynote speaker for the 2020 Safe Sleep Summit, Dr. Linda Battle.
Thank you. When you hear all of that, I'm like, who is that old lady she's talking about? That's a lot of stuff that's done in a short amount of time. But I just want to thank Rachel. How this really came about. I had Rachel in my class, one of my classes last summer, and I was actually, she had some issue. She had a Rachel issue, and she called me, and I was actually in New Orleans preparing to do a talk at a national conference in New Orleans. But somehow, when you have, as a teacher, when you have a conversation with someone and you say, my, she gets it. She really gets this public health thing. And that's, I think I still remember talking to Rachel in the hotel for a couple of hours. I was like, I have to get off this phone. I have to be on the stage in a little while. But you guys are very lucky to have Rachel. I know she did some of her practicum to graduate with you guys, but I think you guys are very lucky to have Rachel. Because she really gets it. Not only does she get public health, but she gets minority issues. So crossing that line, but she really gets it. And when you're dealing with something, especially what we have going on right now with our current political climate, we need to do more. We need more Rachels that are going to really work for the disenfranchised. So I just wanted to give Rachel her props too, because she's really, and it was very funny because we hadn't spoken for probably about a year, because it was last July. She was in, I think she finished my class around September or something like that, and we hadn't spoken, and all of a sudden I got a text message. And so I guess that makes me feel kind of special that after a year she was still remember me in the work that I'm doing. So all right, with that said, I'm going to go ahead. So if we have any little bitty technical issues, we'll be prepared for that. But I'm going to go ahead and start my part of the presentation, and I need to make sure we get this right. All right. Okay, so everybody can just, I want to make sure the right screen is up before we go on. All right, so what we're talking about, of course, we're talking about babies and sleeping on their backs. That is actually sleeping on their backs reduces the risk of sudden infant death syndrome. Before I start, I want to go ahead and recognize Generate Health St. Louis and Flourish for actually having the foresight to come up with this program. If we look at the statistics, St. Louis is really being affected disproportionately by sudden infant death syndrome, and specifically among their populations of color. Also, I want to thank Grand Canyon University, who is one of my employers, my program managers, Sarah Schroyer and Veronica Perez, who have supported me in the work that I've been doing, not only as a professor, but my own outreach and research work that I've been doing for the last several years. Um, this is one of the reasons, and also I want to thank Connect Pediatrics and the leadership there. The owners of Connect Pediatrics are nurses, Ezra and Gina, and Clint Perry. That's one of the reasons why we went over the cap. As soon as they found out what I had been asked to do, Clint did his magic and put it out, and he put it out on social media. I know with Connect Pediatrics, we have over 400 employees. Majority of them are nurses. And of course, this is the population that we deal with. Um, and when you're talking about SIDS, you can have also not only just SIDS, but you can have a what we call a near miss SIDS. So that has been someone who's had the child that's had the incident, but at some point they had been revived. So of course, these children in most cases are going to have some developmental delays and things like that. So that's the kind of population that we deal with. But and also, I want to definitely put a special thanks to the Prue family. That is the family that I actually work for with Connect Pediatrics. They have actually, in this time, and everybody, in the breakout session, we asked, how have you been dealing with the pandemic and being quarantined? Um, as my intro said, I do take care of my 102-year-old mother. Um, and you just don't know, being quarantined and isolated with a 25-year-old and a 102-year-old, that can be kind of daunting. So that's one of the reasons why I actually took this position, to get out of the house. And then another person that I really want to give a lot of recognition to is Rhonda Donberg. She is my partner in crime at Pediatrics, at Connect Pediatrics. She also is one of the nurses that takes care of the Prue family. She's the day nurse and I'm the night nurse. But Rhonda's the one that keeps me on task. She's like, how's your presentation going? Do you have your presentation done? The only thing that I want to say to Rhonda is I worked this morning. I went home and took a nap, but this is the first time you forgot to wake me up. So, and of course, I mentioned Rachel. I want to really thank Rachel for thinking of me with this initiative. Before I go on and really start going into the content specifically related to SIDS, what I want to do is tell a story of a client that I met several years ago at Tripler Army Medical Center. Tripler Army Medical Center is actually in Hawaii. They call it the big, and it is actually pink, just like that. They did it, but they actually service that whole area. So if you have any kind of problems, medical problems, you're overseas, that's where you're going to go, to Tripler Army Medical Center. They are way above, but way above as far as technology. They do all of the training for the Army's maternal child health nurses and maternal child health physicians. But I want to share a story of a young lady that I met at Tripler Army Medical Center. She was there. Her husband was actually stationed in the Marshall Islands, which is about a 5-hour flight um, from um, from Hawaii. It's in the middle of nowhere. So she was known to having high-risk pregnancies, having had a few miscarriages, and finally she did have one son. And when her son was probably about 8, 9 months old, whoopsie, she found out she was pregnant again. But knowing that she had high-risk pregnancies, they decided to have her come off of the island and actually go into Tripler, just in case she had the baby early, that she would have all the care that she needed. Just to protect privacy, we'll just refer to her as Michelle. So Michelle was admitted to the hospital. They have a long-term unit. Basically, that's where we put the mom, and that's where we keep the mom on bed rest. And we do them feed her and grow her. We feed the mom and grow the baby. So she was put into the hospital when she was about 28 weeks pregnant. And things were going along very well. And then all of a sudden, there were some issues. The baby stopped moving as much as in utero. And at that time, she was 30 weeks pregnant. So the decision was made to go ahead and do a C-section on her. So she had her C-section. And then there's her little baby. And of course, on a 30-weeker, it's not unexpected for the baby to be on a ventilator and things like that. So the baby was on the ventilator for a couple of days, was actually doing pretty well. Um, After probably about, of course, when a patient is on the ventilator, of course, we want them to have breast milk. So the mom was, pumping her breast milk, and the baby was getting tube fed. Um, After about 2 weeks, the baby was doing very well and started really moving along. And so they decided to see what the baby would do. So she was extubated. And the first thing the baby did when she was extubated is she was rooting. And we know rooting is a reflex that the infants intrinsically have to breastfeed. Well, everybody was surprised that this little 3 pound, 5 ounce baby was rooting and sucking her lips. So a nurse, she decided to go ahead and try to put the baby up to breast to see if the baby was going to go ahead and feed. And lo and behold, the baby did latch on, which is very rare to have a baby born at 30 weeks, 2 weeks later, start to breastfeed on their own. But in terms of the baby's progress, this was a good sign. The baby's breastfeeding. The less tubes we have, the less risk we're going to have for infection. That's the little baby. Her name was Alexandria Lutrice, actually. And she was actually doing good. She was growing. And if anybody know, when we have NICU babies, one thing that we look for is when the baby reaches 4 pounds. Once the baby is reaching 4 pounds, is eating on its own, is not having major respiratory issues, we start preparing the baby to go home. So as they were doing that, the baby was doing really well. There she is, no more feeding tube. She's feeding either by the breast or by the bottle. But of course, the baby was getting breast milk. She was still being cared for in the NICU, because she did have to still have the monitor on her, but she was progressing very well. From what I was told, the mother one day, just to get out of there, because she was staying in the hospital, to get out of the hospital, she decided to get out, just to get out of the hospital and go to get something to eat. And when she came back to the hospital and she went to the NICU and she looked around and she's like, "Where's my baby?" And somebody said, "Oh, well, she's been transferred to the newborn nursery." Well, any of you guys who work in maternal child health, we know that normally a baby is not going to go straight from the NICU to, with all the bells and whistles, to the newborn nursery, just in an open crib, no monitoring, anything. It's just like an adult. You go from the ICU to the step down, and then you go to the mainstream floor. But lo and behold, we did find her. She was in the nursery. Um, Mom was kind of concerned, and she had some questions. She said, I'm not really comfortable, going from having all the bells and the whistles and for everything to, for her not to be monitored. One of the residents came in and talked to her and said, "Well, it's okay. She's doing really well." Mom still had some concerns. But she said, well, they're the healthcare providers, they know best. So Alexandria stayed in the nursery for 2 days. The mother was allowed to, was going in there breastfeeding her. She was able to bring her to her room to have some bonding time. The second night, mom was so tired, she just decided, she said, I'm going to go ahead and let my baby stay in the nursery so she can be watched because I'm really tired, breastfeeding every couple of hours. She was really tired. So she put the baby in the nursery thinking that everything was going to be okay. For some reason, about 6 o'clock that morning, the mom was awoken. If anybody have anything to do with the military, at 6 o'clock, that's when they're doing PT and they're running. So that happens for the staff at the hospital. So they're hearing all that noise. So she woke up. Mom said, well, I'm awake now. Can't sleep with all this noise. So she decided to go into the newborn nursery. As soon as she got to the nursery door and she was looking around and she looked over, she's like, where's Alexandria? And she looked over to the left of the nurse's station and she didn't believe what she saw. She recognized Alexandria's blanket, but she didn't recognize Alexandria. And she said, oh my goodness, what's wrong with Alexandria? As soon as she said that, the nurses looked at Alexandria. Alexandria was laying on her stomach in the crib and she was blue. The report from the mom says that her little daughter just looked like a smurf. All she saw was blue and blankets and she saw the small face. And so they jumped up and did everything. Of course, they called the code team. This is what we call a near miss SIDS because it did happen. They did bring in the code team and they were able to put Alexandria on life support. From what we were told, um, she was clinically brain dead. They did all of the testing and everything, so um, she wasn't getting oxygen enough and she was clinically brain dead. Now, if you remember at the beginning, I told you that her husband was actually stationed in the Marshall Islands. So he had gone back to work. So they had to wait for him to get a flight in to kind of make some decisions. Of course, any of you guys know, once you're deprived of oxygen, you start going into multi-system organ failure. And that's what started happening. There were no brain waves, kidneys stopped working, things like that, everything stopped working. The only reason why her heart stopped working, did not stop working, because it has its own mechanism that keeps the heart moving. So the woman, Michelle's husband, did get in, and after having all the tests, there were no brain waves. Um, the baby wasn't. There was no chance of any type of life. So the decision was made to actually take the baby off of life support. The parents decided as a team that they didn't want, because eventually the heart would stop. They didn't want the baby to go with the tubes on them. So they eventually did make the choice to go ahead and have the baby extubated. So of course they bring in all the bells and the whistles. From the story, what she said is it was very difficult for the staff. This baby had lived for exactly 30 days. She was born on July 8th, and this happened on August 8th. So they actually, because she had been, it was very hard for the staff that worked in the NICU because until the 2 days when she was transferred, everything was going good. So they eventually brought in a team and had to go ahead and extubate, take the breathing tube out of the baby. And as you can see, once you do that, the baby's not getting oxygen. You don't have the color that you should. And of course, all they're doing is waiting because, like I said, the heart has its own mechanism. So they're just waiting for the last heartbeat. And it didn't take long. Because her baby never went home and she was away from the family, they decided to have the memorial at the hospital. So all of the nurses, staff, respiratory therapists, could pay their respects to the child who had succumbed to what we call a near-miss SIDS. Now I know this is not how we want to start a program like this, but what it is, this is reality. This is things that happen. Think about it. This was a SIDS incident in a major medical center. Um, as I'm talking, if those of you guys who haven't figured it out by now, this is actually my story. Alexandria was my daughter. I was a little heavier there, but Alexandria was my daughter. So it's very difficult. That's when she was doing well. So here I was, a nurse, entrusting my child to the care of the staff, and this is what happened: a near-miss SIDS incident. So, but a lot of people ask me how I'm able to talk about it. Talking about it, actually, it was years before I was able to freely talk about it. But I had a very dear friend of mine who was a nurse. Her name was Marilyn, and she was the one that she was older than I, and she actually helped me to talk through it. And it happened for a reason. She just kept saying it happened for a reason. And for me, it took years, but the reason is to be able to speak so somebody can learn so this does not happen to another child. So now that everybody might have their tissue out, I'll give you a break, take a drink. But we want to go, as we always do when we're doing any kind of presentation, we want to go over the objectives for the program. So at the end of this presentation, you guys will be able to define sudden infant death syndrome, understand the impact of SIDS across the country and specifically in African American communities, apply the basic back to sleep risk reduction practices that help reduce the risk of SIDS, identify and discuss other infant care practices that can keep babies healthy, and understand the impact that SIDS death has on the family. What is sudden unexpected infant death? Sudden unexpected infant death is not always SIDS. Sudden infant death is the death of an infant that occurs under a year age. Usually it's unexpected. It could be several reasons. It could be suffocation, entrapment. We hear all of the stories where the child got pinned in the crib in the mattress. Infection, ingestion. Sometimes there can be some undiagnosed medical diseases or cardiac arrhythmias, and of course we have incidents with trauma. But one of the identifiers that does go under sudden unexpected infant death is actually SIDS. So one thing we need to do, especially within our communities, is say what SIDS is not. SIDS is not the cause of every sudden infant death. It's not the same as suffocation, and it's not caused by suffocation. It's not caused by vaccines or immunizations. We know right now, especially now, unfortunately, as a nurse, I call them tree huggers, those ones who do not want vaccines on their children. And sometimes there's a myth out there that vaccines do cause SIDS, among other things, but none of that has been proven. SIDS is not contagious. It's definitely not the result of child abuse or anything that. SIDS is not caused by cribs. Of course, we know the street name for SIDS is cribs death. SIDS is not caused by vomiting or choking. It is not completely preventable, but we know there are ways that we can reduce the risk of SIDS. Sudden infant death syndrome is the term of the death for someone younger than 1 year old, and it's unexplained after complete investigation. There's been an autopsy. There's been an examination of the death scene. They reviewed symptoms or illnesses that they experienced that the child had before dying, and any other important medical history. Normally, there usually are no other symptoms or illnesses, anything that would alert the family that this could be happening. So that's why we call it sudden. Approximately 3,000 babies die of SIDS each year, even though doctors and nurses still don't know what is causing SIDS. Now, some might say 3,000, that's not a lot. But let one of those 3,000 be your baby, and you might have a different idea about the number 3,000. Most of the deaths occur when the baby is between 2 and 4 months. African American babies are twice as likely to die of SIDS when compared to their Caucasian counterparts. More boys die of SIDS than girls. And also, SIDS deaths happen quickly. And as I said, there are no signs before the incident. And usually it happens quickly with no signs of any type of suffering for the child. More SIDS deaths occur in the colder months. I see that's important for you guys that are there. We don't have that much of a problem here in Texas, but I'm sure what the research is saying that a lot of times it occurs in the cold months. And one of the issues that we have with SIDS research is look at the numbers. The numbers are really low. And so when we're talking about divvying up resources to do the research, we have 3,000 babies dying of SIDS each year, but we have thousands fold that number that are born with conditions such as cerebral palsy and other genetic incidents, other genetic anomalies. There are often myths that are associated with SIDS. Babies can catch SIDS, okay? Cribs cause SIDS, no. Babies who sleep on their back are gonna choke or spit out vomit. That's not true. The same way if you were on your back and you, in fact, just say you went out, had too much to eat, and something happens, you do have a mechanism, a reflex that's going to make you turn over and stop it. So that's not why that happens. One of the myths is only Caucasians babies die of SIDS. A myth is that SIDS can be prevented. And we also talked about immunizations and medications. And another association, SIDS can occur at any age. The primary is age 2 months to 4 months, but it can occur up to the age of 1. So we want to talk about the many ways to reduce the risk of SIDS. One thing, and I'm glad so many people came here, this is something that we need to talk to with our, not just in your formal roles, but with your families, with your neighbor down the street. You know, you always want to place your baby on the back to sleep for naps and at night. You want to make sure that you have a firm sleep surface, such as a safety-approved crib mattress covered by a sheet. When I reading that, thinking about a little baby that's 7, 8 pounds, I can remember when I was younger, probably about 4, 5, or 6, because I can remember it clearly. I used to have nightmares, and I used to go and sleep in. I'd want to get into bed with my mother, and I can always remember that the bed was going down. So I always felt myself rolling down into my mother on the bed. So could you imagine a little 7, 8 pound baby in the bed with an adult and having that shift within the bed and the baby rolling over onto its stomach? Just not thought of. But like I said, as I read that, I still remember that, and I'm past half a decade, and I can still remember those nights trying to hold on to the side of the bed to keep from rolling down into my mother and my father. One thing we want to make sure too is keep soft objects, toys, and loose bedding out of the baby sleep area. If you look on the internet and look at any kind of photos, you're gonna always see all those photos that are just wrong. Just even looking at TV, some of your common shows, you see they have all this stuff. Yes, all this stuff is nice and it's cute and all that, but they should not be in the crib when the baby's sleeping. I know with my son, I was given all kind of teddy bears and things like that. I was so nervous. I had all the teddy bears hanging from a kind of like chain that went down the wall. It decorated the room that way as opposed to putting them in the crib. Definitely, we don't want to allow smoking around the baby. Not only is that associated with the increase of SIDS, but that is also associated with the development of juvenile asthma. So we want to make sure that we keep the area close but separate from where you sleep. And one of the things is using a pacifier. You want to make sure that you have a clean, dry pacifier when you put, if you use a pacifier at all, when putting the child down to sleep. And another thing we need to make sure is, I know I've seen some friends of mine, when the baby's 4 years old still with a pacifier, the pacifier's cracking and all that stuff, and then you see them give that pacifier to the infant. uh, the infants need to have their own. Those of you guys who work maternal child health have all seen that. So we want to make sure that the infant has its own pacifier and that it's in good order. We don't want to let the baby overheat during sleep. So we always say when we're looking at the baby, I said, if you're hot, the baby's going to be hot. I live here in Texas and I see some people, I'm like, why is this baby? It is 80 degrees in this house. It is hot. Why is this baby double wrapped? If the baby's hot, you're hot. If you're cold, the baby's going to be cold. So we need to just pay attention to that. We want to make sure we avoid products that claim to reduce the risk of SIDS. Many of those things have actually been taken off the market now. We have the wedge where you can hold up the baby on its side. Well, once again, here's the wedge, here's the baby. They have not been proven to keep the baby up on their side. So we want to avoid that. And I think several of those you won't see. It used to be probably about 10, 15 years ago, that was all the rage. You spend all this money for all this wedges and all this stuff. They don't work. Another thing is looking at home monitors. Home monitors, yes, they're good so you can see what's going on with the baby, but they're not going to reduce the risk of SIDS. If you remember, I said usually it's sudden. Usually there's going to be no sign of the baby suffering. So those monitors, normally they're gonna, a lot of them will give you an alert if the baby's moving. Well, in SIDS cases, you're not gonna see that type of movement. So yes, monitors are good, but they are not a preventative measure for SIDS. And we're talking about, I know specifically within the African American community, we talk about reducing the chance that flat spots will develop on your baby's head from laying on the back of their head. Well, that's why parents, they need to do tummy time. Yes, baby sleeps on their back at night, but during the day, put them on the tummy. That helps them raise their head, helps strengthen their head muscles, their neck muscles, and it also takes that pressure off the back of the head. But in reality, those of us who work maternal child health or pediatrics, sometimes people are just going to have a flat head. Look at the dad. Dad's head is flat, so it doesn't matter what you do, that baby's head is going to be flat. So that's not a major issue. But a lot of times, that's one of the biggest things that we see in the African American community. I mean, I've actually seen people in the hospital, the grandparents come in and the head is misshapen specifically from coming down the vaginal canal through the birth process. And you'll see grandmas sitting there trying to massage massage the head, trying to make it round again. No, that's not going to work. So we got to be careful with that. One thing we really want to talk about is aspects of family grief. Um, Traditionally, and I know we're concentrating a lot on African American or families of color, um, and a lot of, just because it's how it within our communities, death is a part of life. But a lot of times these families do not actually go through the grieving process. Families that have experienced this loss, sometimes they feel guilty for their baby's death or even responsible for their baby's death. It can happen to any family, no matter what their race, ethnicity, income, or where they live. Since death often extreme grief reactions for families. I did share my story, um, and my ex-husband now, we grieved totally two different ways. He was a man's man in the army. Just get over it. That was his way of grieving. Well, that did not work for me. That was my child that I carried for 30 weeks, that I nursed for 4 weeks. And I just couldn't. And so we see a lot of times we're going to see breakups of families because of that. And basically, it's if we don't get them in counseling to figure out what's going on and they're doing it on their own, a lot of times they're not able to go forward in their relationship. A lot of times, whoops, typing in, guilt, a lot of times they're going to have guilt and feelings of responsibility. One of the biggest things is they're not going to have a chance to say goodbye. Think of a child that develops cancer early on. But during that time, from the time they're diagnosed through treatment, the family has some time to talk, to deal with the child, and to work through the grief. If you hear that bell, sorry, Amazon Prime is delivering. I got the message on my text. I'm like, oh, had to take advantage of those times. The families don't have a chance to say goodbye. They're with their baby one day, the day the baby's gone. Often there is a fear from the siblings. They have a fear of death for themselves or for any of their other siblings. So it's important that we do some type of counseling, grief counseling, not only for the parents, but for the siblings. Often there's despair just for the lack of answers. Why did this happen to my child? I know when I was in the hospital, when it happened to me, I had despair. Not only despair, I was angry. I was angry at everybody. I was angry at God. I said because I I was breastfeeding. I was donating my baby. I was donating my milk. I was giving my milk to infants that were born addicted. So when this happened, I couldn't believe it. I was like, in my terminology, wait a minute, my milk is being given to this quote unquote crackhead's baby. This crackhead baby is alive. I've done everything right and my baby's dead. And it took a long time for me to deal with this. When you're talking about lack of answers, at the time, I was a nurse. I felt, why didn't I see this coming? What did I do wrong? But it wasn't my fault. And then also, you're going to have feelings of being under suspicion. You know, all of a sudden, you're in there and the baby dies, and we're like, oh my goodness. People are asking, family that's not there, you're going to have extended family. You're going to have the in laws. When something like that happens, you know, the people that aren't there, they're always the ones that have something to say. And so the family might go through feelings of anger or feelings that they're being blamed for what happened to their child. So there are a lot of things, but the biggest thing, and as someone who is part of the community, obviously, I'm African American, part of the communities of color, any type of mental health issue, we just have not fully engaged the whole mental health thing that's going on. So, but at any point, we need to make sure that these individuals get the help in the mental health counseling that they need. We want to make one thing, and I know a lot of my students are in here, and one of the, and I know my student can tell you, one of the things that we talk about a lot is how do we spread the word? In public health, we call this dissemination of the information. Yes, it's absolutely great that we have 100 people in this classroom, in this Zoom meeting right now, and we have several others that couldn't get in. But the issue is, it's not enough for us to just have this information amongst ourselves. We need to spread this information. We need to make sure that we're talking to the parents, we're talking to the grandparents. We know as African Americans, we do what my parents told me. Well, my baby slept on his head, so why on the back of its on its back? I mean, excuse me, on its stomach. So why can't yours? And so you're gonna go back and forth with that battle. You need to be able to tell them this is why. And in some point, I've had some that people end up being mean. Well, if you cannot honor my wishes, well, oh well, grandma, I'll see you when the baby gets two. How about that? And then usually they'll go with it. But a lot of times we just do what our parents do. That's how we learn to parent. I know growing up, we didn't know what a car seat was. A car seat was the phone book. And I'm sure if we still had phone books, there would still be some people that would use the phone book for their car seat because that's what their parents did. We need to make sure that we're talking to the aunts, uncles, siblings, healthcare providers, daycare providers, teachers, clergy. Think about it. Going into the church, and you want to they have the church daycare, and you want to have a nice service, putting your baby into the church daycare. Make sure that you have discussed this, and these are your wishes. This is a time for you guys to do outreach with the churches, and it takes very little time to go in there with the staff of the daycare within the church to actually talk about this. Because if you remember, they are not formally daycare providers. They're just the people that like to sit in there and play with the babies. And I know I will admit, sometimes I would rather go in there and work the nursery to sit in that 3 to 4 hour service that African Americans are known to have. But we need to definitely get the word out. We need to talk to everyone within our communities that are concerned with the health and the welfare of our babies. Now, you're going to have a lot of questions when we're talking about SIDS and you're trying to teach people. Some of the questions: can my baby choke while sleeping on his or her back? The answer is no, because they do have that type of reflex that will prevent the choking. What's wrong with my baby sleeping on her stomach? That's how I slept. Those are the kind of responses that you're going to get. What if my baby can't adjust to sleeping on his or her back? Well, if that's what you do from the beginning, they will adjust. It's the same thing. If your baby doesn't adjust to eating vegetables, so you're never going to give your kid vegetables because your baby won't eat the vegetables at the beginning? No, we're going to continue to do what is right because that is what the baby needs. Same thing. Is it okay if my baby sleeps on his or her side? Several years ago, when we first started this initiative, it used to be side or back. But now, through research and things, we said back is best, not the side. And we already talked about the products that are designed to keep the baby in a certain position during sleep. Those have not been proven. Same thing, dealing with the grandparents or caregivers. It's up to the parents that they are the parent and they need to make their wishes known. And then we talked about tummy time. So that is very good. And one thing about tummy time and strengthening the neck muscles, the more we find that babies who do tummy time more tummy time, they actually start learning the skills like rolling over much quicker than the ones that don't do tummy time. Now, I will tell you, if those of you have children, tummy time is work because you have to get down there and see them, and you have to make sure that they're holding their head up and their head's going to go down into the thing, and you're going to think they can't get up. It is work. Doing tummy time, we have to do tummy time too. But usually at that age, when they're young, a lot of times going face to face on tummies, the infants, what they're going to do is they start mirroring what the person in front of them is doing. So if you're on your stomach and you're lifting your head, the baby is going to try to mirror what you're doing. And all this is working those neck muscles. And then again, we already addressed flat spots on the back of the head. And talking about SIDS death likely to happen, it is age 2 to 4 months, but it can go all the way up to a year. Now, for all of you guys, of course, for the academics, when I like to present at a ground level. So whether you're a healthcare provider, whether you're a social worker, or someone who is just interested, they will be able to understand what I'm talking about. But I know I have several of my students that are in this presentation right now, and they are working on their master's degree, learning to be junior researchers. So now we're going to talk about the statistics. About 5% of deaths, SIDS deaths in African American communities can actually be traced to a defect in one gene. Now, we traditionally do not do gene therapy on infants when they're born. It is very pricey. So that's not, they won't know about the gene until after it happens. In one study, they had 265 deaths. 75% of them were African American. And we found through that study, they found that African American parents are more than 3 times likely to put their babies to sleep on their stomach as opposed to other ethnic or racial groups. So what is interesting to know, and this is another study that came out, only 46% of the parents whose children died of SIDS actually said they received advice from their healthcare providers on how to place their infants to sleep. Think about your last visit. They go in there, you tell you what's wrong with you, they say a whole bunch of words and they walk out. But they don't take that teaching. That should be something that is asked at the visit. That is a teachable moment. So, how does your baby sleep? Because usually they'll ask, how long is your baby sleep? That's not the issue. Some babies sleep long, some don't. What needs to be asked is what position. Think about the newborn, how often in that first month they're going to pediatric appointments. They need to get immunizations, well baby checks. You have teachable moment after teachable moment after teachable moment. Now, interesting enough, 25% of African Americans actually had been advised to place their baby to sleep on their stomach, as opposed to the 7% of Caucasian who actually said they received similar advice. So 25% were actually advised to have the baby sleep on the stomach. That's kind of interesting. In my case, in one of the things why I was really angry, why in the nursery in a major medical center was my baby on her stomach? They never could give me an answer. And in all honesty, that's the only thing, because of course when I walked in there, once they realized what was going on, they were trying to pull me out. And that is the only thing. There were 2 things that I remember. I remember her being on her stomach, seeing her blue color. And I remember, weird enough, there were 2 nurses sitting at the nurses station, probably, I guess they were social distancing, probably about 6 to 10 feet away from the crib where my daughter was. And they were eating chocolate cake. So when they were asking me, because of course, when things are going down and they're trying to do, figuring out what was going on, and of course, people are going to deny and say she wasn't. But the one thing, how did I remember? They remember that I was a good historian because I remember seeing chocolate cake, and they couldn't deny it. How could she remember seeing chocolate cake? So if she remembers seeing a chocolate cake, she definitely remembers what her daughter looked like when she walked into the room. So when we're looking at Healthy People 2020, that is what, and these are for my public health people, and I know Rachel knows this very well. Anything that we do as far as looking at the health of our populations within Healthy People, we use Healthy People 2020. And anything that we do on a community-wide level addressing populations, we look at the goals that have been established by Healthy People 2020. Healthy People is actually a huge initiative that is worked on and developed by the CDC, the Centers for Disease Control and Prevention. And under Healthy People 2020, under maternal, infant, child health, the initiative 1.8 is actually to reduce the rate of infant deaths from sudden infant death syndrome to 0.5 per 1,000 live births. Now, yeah, 0.5 doesn't sound like a lot. That would be 1 per every 2,000 births. But let that be your one baby and think about that. So now we went through that pretty good. I wanted to open up for any type of questions, actually sharing any of you guys' experience, what you've had, some of the things that you've heard within the community, some of the myths that go on. So we're just gonna open it up for a general discussion, and I'm gonna stop sharing my screen. I'm trying to get my technical things going there. Okay, is my screen still up?
Mm-mm. To avoid people talking over each other, if you guys either want to raise your hands or drop your information in the chat, so we don't have 100 people trying to talk at the same time, be great.
I just want to address, Mel talked about, if you're not, because you're not able to read the chat, talking about educating the daycare workers, the church daycare workers. Because usually who are the church daycare workers? Grandma Betty, whose baby slept on their stomach, right? So that's something that's really important. A lot of times there'll be some of the youth in the church who have never had any. We know the American Red Cross does certifications for babysitting, stuff like that, but those aren't required in the church. Someone said, are there programs for pregnant teens to understand SIDS? That might be your job. These are things that we need to do. We need to start making sure that we have these type of initiatives, making sure, because we know a lot of, I know you guys there in St. Louis, you guys have a lot of alternative education programs for pregnant moms. You need to make sure that they're discussing that and being serious about that so the moms do understand what's going on.
So you have one question, Asia.
Oh, yes. Are there any conversations with bedding companies?
Can you hear me?
Mm-hmm.
So you have one question, and the question is, are there conversations with bedding companies?
And from what I know, when this first started, yes, we did have conversations, but now all those things are regulated now. So they get it. They get it. The bedding companies, they get it. Because imagine when this first started happening, that's when so many of the beds were being pulled off the market. So that's one good thing about that. If it's going to affect their wallet, they're going to make sure that they're doing right. And those are the things like making sure the sheets fit. Those of you guys, any of you guys, now the sheets they look bigger, but they actually go all the way under the mattress, as opposed to like our mattress at home where you try to get it on, it still pops up. Now the crib sheets, they're actually made bigger, so you have to put it all the way under to keep it from loosening. That's good. Co-sleeping, they say. Yeah, and they say nothing happened. Yeah. Mm-hmm. There was a story, I think, Rachel, if you want to tell the story, wasn't there somebody there about the co-sleeping?
Just my experience when I was working in the PICU as a pediatric nurse in Kansas City, one of the first experiences that I had that ended up shaping my nursing career and ignited this spark was learning about a woman. She had, she was a single mom, had limited resources. This was back in 2013, and she had a 2-year-old and I believe he was 6 months old at the time. All 3 of them were on the same mattress, and I'm sure too, especially during these COVID times, it's common, because limited resources, lack of education, all of that. Fast forward, she accidentally rolled over onto her 6-month-old son that night. He ended up vomiting and then aspirated his vomit. So for those of you that don't know, that means you have stuff that shouldn't be in your lungs, including stomach acid, all kind of stuff. Baby ended up going into a multi-system organ failure, but he was alive. Obviously, he was my patient in the PICU. Ended up having a reaction to the seizure medication, and his skin was coming off of his body. But just being in that room and listening to the doctor explain the reality of it in a way that just for her, because she wasn't comprehending that this wasn't her same baby that she had the night before when she went to sleep. So and I'm sure everybody here, I've been reading the chats, and everybody has a lot of heart-wrenching stories, and it's important to discuss. And thank you for everyone who has shared their stories through the chat. Thank you to Dr. B too. But yeah, just definitely it's so important to touch base and to continue to spread the word about safe sleep awareness and what SIDS is and what can you do today, right now, to help make sure every baby, regardless of their color of their skin, has the equal opportunity at having a healthy life.
And no matter where you are, this is such a big initiative. The NIH, and actually it was through one of the I miss who did it. She was a big humanitarian. What's her name? I can't remember it. Oh,
Shriver? Is it Shriver?
I couldn't think of her name. I just remember the guy got shot, Red Let That family. But she was the one that just really, what's her name? Whoever said her name.
Maria Shriver.
Right. It was really pushing on behind this initiative with the NIH, coming up with the Safe Sleep SNAP. It's a campaign put on by the National Institutes of Health, or the NIH. If you just Google Safe Sleep, you will come. They have a whole toolkit, and in several areas, it will have, whether you're talking to the layperson, whether you're talking, and it's, you don't even have to do it and put anything together. They have everything for you. They have how to teach it, what you should say, what all the myths are doing, all the myths that are out there, how to present information so people aren't believing the myths. We were talking about, I remember when Rachel first called me, when we were talking about how sensitive a topic this is, she told me about an incident with a physician whose baby, he had the infant on his chest. The baby was on his stomach, and the baby had a SIDS incident. He woke up because dad, you see all those pictures on TV and it looks really cute, dad bonding. Well, dad fell asleep. The baby had a SIDS death. When he woke up, his baby was dead. So it is a reality. And I'm just reading some of the stuff on this side. Anybody else have any questions? Oh.
So Tara Goins posted that the Missouri Safe Sleep Coalition completed a training for public, parents, and caretakers, as well as service providers, to educate on safe sleep practices. And the link is included in the chat. So she said the training is not successful when using Internet Explorer. So you can copy and paste it into Google Chrome. So that's over in the chat box for those that may want to take part in that.
And we'll also, since this is going to be, that resource will be shared, because we're going to share the recording of this. So resources will also be shared when you get sent. If anybody who's registered, they'll get sent the resources also.
And there's also a question from Asia. Education is required for state daycare facilities in Illinois, and this is open to anyone that can respond back. How can we get unlicensed daycare workers to have those same requirements, or at least extend the education to them?
If I were put in that situation, because remember, every daycare is not a licensed daycare. You know, think about it. I'll be honest. My neighbor across the street, because she was home with her grandchild, that was my daycare. I'm like, cool, I paid her. But that's why we need to make sure that the parents know. And that's what I keep, this is how I want you to do. This is what I want you to do. So we need to make sure, because the licensed daycares, they have the information, but I bet you any of you, now that you're aware, some of you have kids, start looking around and see how many times you go in daycare and look in the baby room and see how many babies are on their tongues.
I see another question. Some of our nurses have had the chance to sit in on child death reviews, which I think has been very impactful for the nurses. Do you feel anecdotal situations are the most effective for teaching clients? Is there a line between effective tactics for sharing stories versus overwhelming clients with tragic stories?
For me, since it's what I do, to me, we see so many things, it's putting a face to the situation. No, it can't happen to me. No, it can't happen to me. Yes, it happened to me. And so this is the way I have, in different formats and stuff, I have actually told not specifically for a format like this, but I've used it with my students same way, because then they're paying attention to the story and they're so sad and everything. And then they realize, oh my goodness, that actually happened to Dr. B at the end. You know what I mean? So putting a face with the reality that is sudden infant death syndrome. And we do everything else. We're talking about overwhelming them with tragic stories. If we just look on the TV, we have all these childbirth reality shows. That's overwhelming too.
So there's another question. Dr. Linda, what is the benefit of tummy time?
And that is one, it's helping and strengthen the muscles in the neck. If the baby ever goes over on their stomach, they're able to turn over. When we do tummy time, we're actually strengthening the neck muscles. Strengthening the neck muscles also clears out their throat. They're able to clear their throat and do things like that. And also because so many are worried about the flat head. So if we have them, sleep this way, but we're up doing our little tummy time. And it's, like I said, the babies, if you ever do it, if you go face to face with them, and you're this way, because you're not going to put your face down, although the baby will put their face down, but they're going to mimic you. And basically they're just doing their exercises with their muscles, definitely strengthening the muscles in their neck. And I mean, that is even something that we do with our patients now that are older. Of course, the patient that I care for, who's almost 11, we do tummy time with her, because she's not ambulatory, so she doesn't walk around. So most of the time she's on her back, turn to a little bit to the side, turn to a little bit, because of course she's not an infant, but still we want her to use, because if she's just laying in the bed, she's not using her neck muscles except turn this way, that way. But when we put her on her tummy, she's lifting her neck up and down and strengthening those neck muscles.
There's also a link in the chat box for the benefits of tummy time from the NIH website. Thank you for sharing that, Rachel. There's a question, should there be some sort of time restriction when using baby carriers with babies when they're facing you, or some type of warning? I think that's what the question's asking. So pretty much if a baby is in a baby carrier and they're facing you, should there be a time restriction on how long that baby should be in a baby carrier if they're facing you?
You're talking like one of the slit ones? Is that where?
Yes, yes, I think that's what the question's asking.
No, that's positive bonding. You right there. So, and any mother, you're only gonna hold them along. So you only gonna hold that baby so long. You gonna put them down. But that we encourage that for the bonding process. So.
Thank you.
And I know a family, my godchildren, they are from the Congo, and the last set of kids they have were twins. And I just had to give it to her because she wrapped both of them babies. I don't know how she did it. She did everything, vacuuming, doing everything, but those were the quietest babies I have ever seen in my life because mama was always there. I was like, how do you do that? She used to braid my hair. Baby's right there, and she feeding both babies. You doing that? But yeah, that's something I wish, that's a thing that most countries except, the US, we haven't gotten there yet. But if you look at even a lot of the Hispanic, African, Colombia, whatever, that's what they do. They hold their babies close to them.
There's a question. Do you have a way to access your story or similar parents' experiences that can be used with clients for teaching?
And actually, for those of you guys here, it is being sent to you. The presentation is being taped, and I have given permission for you guys to.
Thank you for
That's
that.
right, Aja, right? Just want to make sure that was correct. Yeah. So I give you my permission.
There's something in the market called OLED to monitor oxygen saturation. Do they help at all? Dr. Linda, Dr. Bree, I think that may be a question for you guys.
One thing with the oxygen monitor, you're gonna have more because it's gonna go off if the baby's toe moves. You're gonna have, so that's not something that we just use common practice.
And the other thing to be aware of is that because those are pulse oximeters, they can actually burn babies. And so it's really important to make sure that you're moving the location. And since parents put babies down and then don't go back sometimes for 6 or 8 hours, we do see babies in the ER with burns from them.
The other thing with the owlet is that it's on that little stock. It's like in a little sock. And as Dr. Colvin stated, with it being a pulse oximetry reading, if that sensor is not exactly in the right place, or if it moves, or if the digit is cold, you're going to get an inaccurate reading, and the alarms are going to go off. So it really just increases that parental anticipatory guidance and anxiety. And if we're going to put that sock on their foot, what do we want them to do with their foot? Kick their foot. So displacement of that sensoring monitor is very frequent.
Thank you all for that. That's good information.
And just to touch base real quick too of what Dr. Battle said, I know a lot of people turn to social media, especially in these days, for parenting advice, or maybe just to have the confirmation of what they already are doing. So one thing is to kind of help normalize safe sleep, just like the image of it and what it looks like in our social media feeds. And you can follow specific hashtags. And I know the NIH this year, because October is Safe Sleep Awareness Month, their social media campaign is, if you follow the hashtag, it's Safe Sleep Snap. So it's a photo of a baby in a safe sleep environment. But just following that hashtag, kind of helps normalize safe sleep, and how that, we need to be sure that everywhere we turn to look for advice or to get education, that we are getting the accurate and correct information.
Another thing to add on to what Rachel was saying, I know within our within our system and in our hospital. Remember that at your agencies, that your PR and marketing people may not have a degree in what best practices are. And thanks to our Safe Sleep Champions, we have been able to detect children inappropriately fitted in a car seat. They're a cute kid, but it's sending the wrong message. Babies not sleeping in a safe sleep environment. So we were able to, be the eyes for your PR and marketing team to advocate for your babies.
Do we have any more questions? We have time for a couple more.
I just want to commend the team that put this together. I think I can honestly say one of the best things that happened for your initiative was COVID-19 in the quarantine and having had to cancel the face-to-face meeting. I can tell you right now, within this group, I have a student of mine who is in Switzerland, who is on here. I have a whole bunch here in Texas because my employer, Connect Pediatrics, I mean, as soon as I called him, because when I was sending the stuff to Rachel, I said, oh my goodness, let me make sure I let them know before I get sued because they see their name come up somewhere. So I called the chief operating officer and literally within 24 hours, he sent it to our 400 nurses in the field and also in the office. And I'm glad that you have it taped because this is going to be something that if ones that weren't able to make it, hey, hit the button and they can all watch it, things like that. Because of my students at Grand Canyon who are all over the country, I have five classes going on right now that I teach, and I sent it to all of them. And every day I was getting, I'll be there. I had some that couldn't get in, but it'll be a good thing because I'll put the link to it to the class. So that's probably about 80 people right there, and it is a public health initiative. It's funny. That's why I will take the blame for you guys having so much. It was put out on, because your stuff is really out there for St. Louis because it was actually put on LinkedIn. It was put on LinkedIn and Facebook, and all of you guys' hashtags are there. And because of that, people who are on my LinkedIn saw it, which one of them was actually she was my dean where I got my doctorate degree in Massachusetts. When I got my doctorate 11 years ago, she was the dean. She's now the president of the college. She actually called me yesterday. I felt kind of special. And she said, can I have the sign in? Which she's sending it to her students up there in Massachusetts. So that's that one little thing where you think you're doing something, or, because, we're trying to, it's the first time we're doing remote. Can we get it right? Y'all got it right.
Wow.
It
Well,
didn't
thank
cost
you
much. You didn't have to pay
so much.
nobody no lunch or donuts or anything like that too, huh? Saved on your budget.
There you go. And next time we'll make sure that more than 100 people can get in. But thank you so much. Wow, that was
Just imagine how many didn't, because I was getting a whole bunch. So that's just the ones that know me personally that have my phone number. I was like, oh, okay.
Exactly. Well, thank you so much. Tons of wonderful information. Still some more great information to come. I'm going to turn it over to Vicki, who is going to talk through some, apologize for you if you're not in St. Louis, they're going to be more local resources for infant loss and infant grief. So Vicki, all you.
Hey guys, I had to get on my iPhone, or I hope you can see me okay. Thumbs up, Asia, am I good? Okay, perfect. Wow, that was such a compelling story. Dr. Linda, thank you so much. And it kind of speaks about what I want to talk about, these resources in the grief arena, because when you have that peer-to-peer contact, and sharing resources, that seems to be the most compelling way for our families to connect. So I'll speak to you a little more about that. But are you going to share the PowerPoint that I sent you, Asia? Great, thank you. So I am going to talk about some resources for grief support. And if I keep tagging in and saying, can you see me? Asia, could you give me a thumbs up to let me know? Because it's really hard to see on this little tiny phone screen, sorry. And if I look over to the side, it's because I have these notes here and I had to rearrange everything when my computer went out. You know, virtually, hey, we can connect with a whole lot of more people, but sometimes this electronic stuff can be a pain in the you know what. But we can go to the next slide, please. So here are some local organizations. Of course, I want to give you some things on the grief resource, but my list is not a comprehensive list. And this is some resource sharing time. So I would love to hear from those who have grief resources that I may not know of, or you want to share with others. This is an opportunity that we can do that. I want to give you my local organizations that are my go-to for grief resources, and then we're going to also look at some national organizations as well. I'm going to start with my infant loss resources here, where I am the executive director. And what we do here, what we call our grief resources, is family support. We don't talk about grief as in counseling, but we're talking about it as in supporting others through their grief process. We know that, and we believe that each life, each death, each baby, and each relationship is unique. So we don't have one approach. It's not a cookie cutter. It comes in different forms and it comes in different ways, and it also helps people differently. The things that we do here, we offer family support as in a home visit, which now we're doing virtual, and we were doing over the internet, or we will just meet with the family or talk to them over the phone, that kind of support, because sometimes people want that. We do a group support, and a lot of our parents now seem to want to do a group support, but they don't want to do as it with other people who may not have shared that similar loss. So when I say that, I mean that we connect them peer-to-peer contact, and our peer-to-peer mentors. These are people who have had a loss, who reach out to new bereaved parents and walk them through things that they may be approaching as if going back to work. How do you handle that? How do you talk to someone who say, how's the baby? And they don't know that you didn't bring a baby home. What we've done here, that we take a lot of our surveys when we talk to our families and let them say to us, what exactly is it that works best for you? Why is this working for you? And tell us what we can do to reach others. And what they've said, 95% is that when I share my story, it's helping me to heal as well as helping that next person. So we really think the peer-to-peer contact is our go-to when we go through this grief resources. We also have, parent support. Sibling support is a lot different than parent support. Grandparents support. Grandparent support is different than the parent support. Grandparents grieving because their child is grieving. Grandparents want to know, how do I help my child through the loss of his or her child? So that support is different. So we have different groups that just are grandparents or parents or sibling. We have some extended family members who may want to know, how do I handle talking to I'm sorry, I had a call that was coming in. How do I handle trying to talk to my sister, who I have 3 or 4 babies, and she was trying to have one baby and that baby died. I don't know what to say. So we actually work with families to share that and help them through that process so that they can help their family members through that. As I did point out, it's not one way. It's different things that we do, and we try to make sure that our families feel the support, that we're here for them no matter what that journey may look like. We are here to support them any way that they want us to support them. Now, I didn't mention though, but today, and it's so unique that today is Pregnancy and Infant Loss Awareness Day. And at 7 p.m., you can join, it's called Wave of Light. And the Wave of Light is where you light a candle at 7 p.m. It's a national, it's going to be all over the world. People will light a candle in remembrance of babies that are gone too soon. So that is 7 p.m. tonight. Just wanted to put that little plug out there. But we do a lot of our online support and our Facebook support. Some families are really, they just really want to do the Facebook support and they don't want to be in a group. We have telephone support. We have email support. Anything, as I said, we offer that support for families to move them through this grief process, because everyone's grief is unique and it's not the same. That's what we do here at Infant Loss Resources. We have a Linden library, but with that, we can give out books. Try to put this in the chat later, or Asia, I'll give you some podcasts that families can use and share with others. But there are a lot of other resources like that. And that's our information there. We also piggyback with St. Louis Children's Hospital, the bereavement program. The St. Louis Children's Hospital has a wealth of knowledge when it comes to the bereavement. Most hospitals have shared chapters, which I'll talk about that later. But when you Google St. Louis Children's Hospital and look at their bereavement program, you're going to see a lot of organizations that are national organizations where you can put your zip code in and they will tell you about chapters that are close to your house, or events that's going to be happening. Right now, I think they're doing a lot of things virtually, but the chaplain there, Jonelle, she has a wealth of information to share on grief resources to families, siblings, and different places there. So if you Google that, you will find that they offer that list to anyone who needs it. And it's also, as I said, whatever your zip code is, they'll let you know. Next slide, please. Asia, do you have the next slide? Thank you. These are our national grief and bereavement resources that I thought I put in. And like I said, it is not a comprehensive. There's a plethora of other organizations, or you may find something at your local church that's doing grief support, but these are our go-to ones that I can tell you about. So First Candle, it's kind of hard for me to see here, but First Candle is dedicated to reduce the rate of sudden infant death. And it also has a 1-800 number. So they're like your 24-hour go-to with a counselor or someone there to talk to you. So that 1-800 number is a 24-hour grief line. And they're counseling anyone day or night. That is really helpful for people who may, at the middle of the night, they just need to have someone to talk to. You can really chat with a counselor at First Candle. So that is that one. I want to tell you, they also have a peer-to-peer online support where they connect people of like similar losses to each other to help each other through their process. First Candle also has like a store where you can buy maybe a brochure or something to pass on to someone else. That resource is always good to have because it's also helpful for people that are in OB offices, clinics, just not at the hospital, but any place where you may come across a mom that has had a sudden infant death or miscarriage of stillborn. That brochures or that information may be helpful for them. So you can do that on the First Candle website. The next one I want to talk to you guys is Mothers in Sympathy and Support. And it is basically the MISS Foundation. In the MISS Foundation, a lot of people they're volunteers that gone through a certified comprehensive, certified compassionate brief care. With that, they have training to help you through the services of families experience the death of a child. They deal with a lot of traumatic grief, and those providers specialize in that. So those are with the Mothers in Sympathy Support. You could also look onto that link if you think this is something that you may want to do, and you can become a certified compassionate bereavement care person. The next one is Grieving Dads. And Grieving Dads is a man that actually had 2 babies lost. He lost 2 children, and he, like Linda had pointed out, when it happened in his life, he just went to work. He didn't go through any counseling. He didn't think he needs to do any of that. He just said, okay, I got to pull this up, keep moving, and just go to work. Well, he found out down the road after he had, I think, some instances with alcoholism, that he needed to focus on how do men grieve and what's the grieving process for men. It is totally different. We all, as I pointed out, everyone grieves differently. So that is his focus and what he wants to talk to. He's published a book on Grieving Dads, To the Brink. Great book. I read some of it, not all of it, but it's really a good resources for men. I can't see any chats, Asia, so I hope you still have that going on. Bereaved Parents of USA is founded by a group of bereaved parents. It's a local chapter here in St. Charles and West County. They're connected with parents who have had losses, and they share stories and learn to rebuild their lives. And that's the Bereavement Parents of USA. They have a lot of chapters all over. The next one is Compassionate Friends. Compassionate Friends have over 660 meetings. Their locations are around the country. They have them in small towns, large cities. Everyone is just like you, so everyone there has had a grief or going through that grief process. So they're not therapists, and a lot of people talk about this. When you do grief support, it's grief support. It's not, there's a big stigma on mental health. The stigma on mental health, and especially in the African American community, we find that if we talk about support a lot more than we talk about mental health or mental awareness, we really just let people know that we're here to support them, whatever that support may look like and whatever that support they need. So we don't provide the counseling, we do provide the support. In the hospitals, you would be more familiar with SHARE. And SHARE is a pregnancy and infant loss. They have a national organization with over 75 chapters. I'm thinking about 30 states. But most hospitals have a SHARE chaplain or a SHARE person. When a baby has passed away or is no longer with us in the hospital, they will have them connected with the SHARE. And their mission is pretty much like ours when it comes to the grief part. However, they focus primarily on miscarriages, stillbirth, and in the first few months of life. We are here at Infant Loss Resources. We focus throughout the first year of life. We have a great relationship with SHARE when I feel that families have reached out to us. And I'm sorry if I didn't mention this in the beginning of this, but all of our support and all of our grief resources and grief support is free of charge. But when we have a family that we think could be benefited or is advantageous for SHARE, then we contact SHARE and we talk to them about the family, and we do that warm pass off. We never want a family to feel like, oh, they just called us. No, we can't help you. No, we only focus on this. We make sure that we find the resource for them and we do a warm handoff so that they could feel connected to this next part of that resource. And if they're seeking us, I'm sure that they are in need of help. So SHARE, like I said, focus on pregnancy loss, stillbirth, or miscarriages. I can't see my chat. I'm on this tiny, tiny phone.
I think people are
That's the end.
sharing some more resources. I haven't seen any questions yet.
Oh, okay. All right. So what did you say? There's no questions?
Correct. But if anyone
Oh.
has questions, feel free to drop them in the chat. We still have a couple more minutes.
There was also, I just want to, and I'll give it to you, Asia, so you can add it to the list. There's another group. It's called Resolve Through Sharing. It's a non-profit group through Gunderson, Luther, something. But it's RTS. And they train both lay as well as medical people in for grief counseling and things like that. I like them. In fact, everywhere, as you said in my bio, I've been the director of perinatal services a couple of times, and I always brought them in. All I had to do was provide lunch. You know, they bring the people in to do the training. It was invaluable training for me, and so yeah, it's very interesting. And a lot of times, ones that would come in addition to my clinicians and my nurses were people who had shared a loss, and they wanted to share their story, and they wanted to be able to give back, and they made some of the best counselors. And I was able actually to use the lay counselors. Once they were trained, I was actually able to use them. So if we knew someone on labor delivery side who we know was coming in, stillbirth, whatever, was having a loss, of course, it's a lot of work for the nurse because they still have to do all our nursing care and all that, and we don't have the time for all the lovey-dovey. I'd call one of my lay people, I need you here, and they'd come in there and do all that stuff so the nurse could focus on what she had to do as far as getting this situation to an end. So, but I'll send that to you. That's just another great resource that I like.
Yes.
We have a question in the chat. Are there any resources for men to assist in engaging them with safe sleep practices and education? And I think this question comes from St. Louis, and I can answer that one internally. And within St. Louis Children's Hospital, the answer to that is yes. We actually have a Safe Sleep Champion within the Raising St. Louis program, and I can send that link to this particular person. I think it's Ricky. I can send you that information to that Safe Sleep Champion, and they can help coach you. And if you have a group of individual men that would like to receive that type of safe sleep practice and education, we do have a Safe Sleep Champion that can help you with that. Thanks for that question.
And also to let Ricky know that here at Infant Loss Resources, we've connected with the Families and Fathers Support Center, and we have virtually trainings there to talk about safe sleep with the dads there in that program. And we've done, I think last month we had one since the pandemic. First we were going inside doing maybe a couple of months. And just last month, we really got back connected to them virtually. And now we're doing them virtually with the young men and that are at the Fathers and Families Support Center here in St. Louis.
Awesome. Well, since we just have a few minutes left, I'm going to pass it to Shaniko really quick to talk about a resource that was shared with us and they were not able to be here today.
Right, thank you, Asia. So I'd like to share another community resource that partners with the community because that was a gap that they wanted to close. It's called Saving Our Babies, and it's led by a clinician, and her name is Joyce West, and she's actually doing a training with parents as teachers right now on infant loss and sharing some stories. Her information, I shared it in the chat, but I'll share it again. And right now they're doing virtual home visits, but they offer virtual support groups and referrals as needed. And for people to participate, they have to go on the website and fill out the form. And it's just a general form where you fill out that you know someone or that you have experienced infant loss. And within 7 days, they assign a clinician to you, and they'll reach out to that person and to provide whatever type of counseling, whether it's one-on-one or group support counseling. And thank you, Asia. That's the information over in the corner. It's Saving Our Babies, and we'll also share that along with the other resources for you all. So that's the quick plug for that. And that's also offered in the community, and it's all free services that are offered. And occasionally they do offer diapers and other resources to the families. But they are virtual right now at this time.
All right, thank you so much. I'm going to stop sharing my screen so I can see if there's anything happening in the chat. But we are at almost about time, and I do want to be respectful of everyone's time. Thank you so much for joining us. If there are no more questions or anything, then I will pass it to Brianne.
So we from the IHAT team just wanted to thank everyone for joining us today. We want you all to take Safe Sleep Awareness outside the month of October, which is SIDS Awareness Month, and promote it all year round. The Infant Health Action Team would like to announce that the Safe Sleep City Guide that's available on the Flourish website that will be sent in links to your email. The team looked at what was being done around the country, incorporated a racial equity lens, and assessed activities based on impact and feasibility. This guide is also in alignment with the strategic plan of the Missouri Safe Sleep Coalition. We hope you use this guide to generate ideas about how to promote safe sleep in the St. Louis region. There's also a Safe Sleep Champions virtual training that is next scheduled for Friday, November 6th from 9 to 11 a.m. Again, the link to that will be sent to you in your email. This training teaches individuals about the ABCs of safe sleep and discusses how to best talk to families about safe sleep. And this is open to everyone. It's free, and anyone who wants to promote safe sleep in the community. So please let us know if you have any questions. I know there'll be a survey sent out to everyone, and don't hesitate to email us with any further questions or ideas. And so thank you.
Thank you so much, everyone. Have a great rest of your day and weekend.
Thank you.
Thank you.